Welcome, everyone. Good evening. I am very excited to be here with you tonight. My name is Carla Sanchez, and I am the chair of the Diversity, Equity, Inclusion, and Respect Committee of the Rochester local section of the ACS. And we are here very excited to celebrate the 4th edition of our Better Together seminar series. And tonight we have the greatest honor to be hosting Dr. Nadia Granger from the Monroe County Office of the Medical Examiner. So now James, please, he's going to introduce the team, the people that make this happen.
Hi, everyone. My name is James Stair, and this is our Diversity, Equity, Inclusion, and Respect Committee members, chaired by Carla Sanchez with Vice Chair Alana Stinnett, and our communications officers, me, Jim Reynolds, and John Fuchin. This past year, we also put together part of our Diversity, Equity, Inclusion, and Respect statement, which is we welcome all people regardless of race, disability, ethnicity, gender identity, nationality, race, religion, or sexual orientation. Inclusion is one of our core values, and we are committed to fostering and promoting diversity at all levels of the organization.
And of course, this DEIR project wouldn't be possible without the support from ACS National. And the DEIR grant that we got supports 3 major goals. It supports our goal of building awareness around the broad array of careers in chemistry available for our students, broaden their perspective of this chemistry spectrum of opportunities that they can use, they can look for. It also promotes representation and provides a platform to get advice on establishing and maintaining a productive professional career, as well as to kind of understand where this motivation from the speaker comes from, of becoming the scientists or engineers that they are now. Like, what was their kind of gravity assist to get to the point that they are, of their careers.
But today's agenda is, first we will hear the presentation by Dr. Nadia Granger. Then we'll have a Q&A session and some quick closing remarks. So a little bit about Dr. Nadia Granger. She got her BS in biology at Brooklyn College, got her PhD in medicine at SUNY Downstate Medical Center. She did a 4-year residency in anatomic and clinical pathology at the University of Rochester. She also did a 1-year fellowship in forensic pathology at the University of New Mexico. She became the associate medical examiner in 2011 and chief medical examiner in 2016 for the Monroe County Office of the Medical Examiner. She has board certificates in anatomic, clinical, and forensic pathology. She's also a clinical assistant professor of pathology and laboratory medicine at the University of Rochester, and did many invited lectures for various workshops and symposium and numerous other local hospitals and law enforcement training sessions. She also is the Forensic Pathology Fellowship Program founder and director in a collaborative program between the University of Rochester and Monroe County. Without further ado, Nadia Granger.
Okay, so I'm going to try and do a quick less than 40-minute talk about being a medical examiner and what I do in my life as a forensic pathologist. So we are governed by the laws of New York, specifically Article 17A, Sections 673 and 671. It involves medical examiners here in Monroe County. Outside Monroe County, where the Office of the Coroner has not been abolished, there are coroners who don't necessarily have to be medical professionals. They can be elected or appointed by their county government. And they're responsible for examining cases and determining whether or not those cases fall under the jurisdiction of the medical examiner. As I mentioned, here in Monroe County, we're dealing with medical examiners. There are currently 3 medical examiners. We are hoping to add a 4th relatively soon. The medical examiners in Monroe County are forensic pathologists. That means they have 4 years of a collegiate pre-med type degree. I graduated with a Bachelor of Science in Biology. There is a 4-year medical degree. Depending on whether or not you want to focus on clinical pathology as well as anatomic pathology or just anatomic pathology, there is a 3 to 4 year postgraduate residency. And then there is a 1-year post-residency fellowship that concentrates on forensic pathology. So I gave you a couple of terms there with respect to pathology. Pathology is the study of disease. It's broken down into 2 main categories: clinical pathology, which is the study of disease based on body fluid. And the easiest way to think about that is if you've ever gone to a lab and had your blood drawn or had your urine analyzed, those labs are typically run by a clinical pathologist. Anatomic pathology is the study of disease based on body tissue. And that's everything from a spot that gets removed at the dermatologist's office to an organ that gets removed at the time of surgery. And the easiest way to think about anatomic pathology is if you've known someone who's had a diagnosis of cancer, that's because an anatomic pathologist has looked at the particular organ. They've identified that cancer, passed that information on to a primary care physician who's then notified the patient of their diagnosis. Forensic pathology is a subheading under anatomic pathology, and it is the study of sudden and unexpected deaths. We have the jurisdiction and authority to investigate a number of different scenarios, including deaths of inmates, deaths involving law enforcement, deaths in homes or group homes or any kind of institution that is not a hospital or medical care facility. But typically we get involved in cases of violent death, whether they be criminal violence, suicide, or casualty. So that involves accidental deaths, anything from falls to motor vehicle accidents, sharp force injuries like broken glass. Drug overdoses fall under this category typically. And if a fire is accidental in nature, then we are also involved. Suicidal deaths are deaths where there is an intent to harm oneself, and that can be blunt force injuries like falls from heights, sharp force injuries like incised wounds, gunshot wounds, again, drug overdoses, and cases of self-immolation. Typically, I refer to the other category as deaths at the hands of another. And that's because when I infer the term homicide, there's an automatic expectation that there is some kind of criminal nature that's involved. And that's not typically the case. Homicide is more of a forensic term. Murder is the criminal term that usually involves some kind of prosecution. So there are cases of blunt force injuries. If someone is pushed and ends up dying, then that is the death at the hands of another. It may be an accidental push, but if that death results from that push, then it is a homicide or a death at the hands of another. Sharp force injuries, again, incised wounds, stab wounds, gunshot wounds, of course, cases of poisoning, so arsenic, ethylene glycol. And if a fire is started with the intent to do criminal damage to a particular location or is done so that someone will die, then that is referred to as an arson fire. And if someone dies in that process, then the case is referred to our office. So how does this work? Our phone rings and we find out that someone's dead. So there is a medical death response or a scene response. And the reason why response is in quotation marks is because there are some deaths that occur in hospitals where our investigators will not go to the scene, but they will get information and do an investigation over the phone. Now, one of the major misconceptions that we have is that we drive out to our scenes in Hummers and we're always dressed in high heel shoes and we have on suits and fancy gear. The only time that I am dressed like this is if I have to testify or if I have to see wonderful people like you and I have to do a presentation. Other than that, I'm in business casual. I have on, fancy pants and a shirt that is conducive to a work environment. These are some scenes from my investigators, and these are images that were taken from press. And you can see our van is not a Hummer, it's just a van. And our investigators typically show up in white shirts and black pants. We do carry badges and logos that identify us as being from the medical examiner's office. There are some offices that don't have a uniform, and so they may go out in khaki pants and polo shirts, but we try and be as professional as possible without wearing our Gucci shoes out to the scene. So next we need to do a death confirmation and identify time of death. Again, we can see the time of death is in quotation marks and it's for the following reasons. So it's a little hard to see, but the little quotation on the bottom says, his damaged timepiece stopped at 5 p.m. That's probably his time of death. And over here, we have another one that says we have the murder weapon, we have a motive, now we need to establish a time of death, although all the clocks are saying the same time. So how do we identify time of death? Well, there are certain things that we can look at that give us an indicator of the time that has passed since someone has died. And the first thing we'll look at is temperature, or alga mortis. And the body tends to lose temperature in 3 different ways. We do it by radiation, we do it by convection, and we do it by conduction. A long time ago, medical examiners thought that we were really smart and that we had figured out an equation that would allow us to tell how long it had been since a person had died based on the rate that that person lost temperature. And the equation ended up with a linear straight line that decreased across a time period. The issue is that that equation started to bend, whether or not it was hot or whether it was cold, whether somebody was heavy or whether they were thin, if they had, whether they were cold, healthy, or whether they were sick, if they were wearing tons of clothing. All those things modified that equation. And what we were left with was more of, oops, going too fast. Let's try that again. Oh, that's not working. Okay, so what we ended up with was more of a curve than a straight line. And that curve started with a plateau. The body tends to maintain temperature for a certain period of time before it starts to drop. And there we go. For some unknown reason, that was not showing up. There are cases where a body will actually increase in temperature before it starts to make that dive down. And what we learned over the years is that if we didn't take all of those variables into consideration, then there was a strong possibility that we would be making errors with respect to time of death. So this is livor mortis, or blood settling. And if you take a look at the tubes on the top left of the screen, you can see that even when you take blood in a tube, that after a while it settles. The red blood cells and the platelets kind of settle out, leaving that plasma on the top. And the same thing happens with the blood in the body. It tends to settle with respect to gravity. It starts in about 20 minutes to 2 hours. So we can see already that we're starting with a very big range. But if you look at the photographs on the left half of your screen, you'll see that when the hand is pressed into the body and removed, you can see a faint outline of that hand immediately after the hand is removed. However, at the time of autopsy, which is that last photograph at the bottom, you can see that again, the blood has settled into that area and it has fixed. When it fixes, the red blood cells actually move into the soft tissue. And so when you apply pressure and you move that structure away, the blood does not return to that area. And we can see that in the pictures on the right. Initially, you can see the imprint of a hand, and that's because that hand was applying pressure to that area of the stomach, and the livor fixed into the tissue before the hand was removed, leaving the imprint of that hand in place. Again, when we take everything into consideration, those ranges that we talked about before, where it was blanchable or not fixed and fixed, those numbers start to move out of place. And so again, we're talking about variables that are changing the determination of the time of death. And then we move on to rigor mortis, or the stiffening. And people talk about death grips and cadaveric spasms. And that starts in about 30 minutes to 2 hours. And what happens is in your body, there's that energy molecule ATP. And as ATP breaks down, it releases energy and it causes the muscle to flex. In the flexing of the muscle gets stiff, and whatever position that body is in at the time begins to get more and more fixed, because the muscles will get stronger and stronger. As with everything though, as the muscle fibers begin to break down, the muscle starts to break down and it starts to relax. And there are points you can see in this photograph where basically the hands are just lying flat against the sides, hanging off of the gurney. That's because the muscle fibers have now broken down, allowing that muscle to release. And it can be absent or completely gone in 36 hours to 6 days. Again, we're talking a wide range. Again, when we throw those variables into place, again, we are making that range wider and wider, taking us away from that definitive time of death. So what do we do? Well, we take what's known as a last known alive time. That is the time between when the decedent is last known alive by a relative, or they may have made a phone call, or they may have purchased something at a store and we can see a store receipt with a date and time on it. When the medical professional or the medical investigator goes to the scene, does their evaluation, and they determine that that person is no longer alive, that's referred to as a pronouncement time. And the time of death falls in between the last known alive time and the pronouncement time. So we are not able, like they do on television, to say that person died at 3 o'clock on Sunday afternoon. When they do that, I do this. Okay, that's not possible. What we can say is that we know that they were alive at 3:30 and somebody pronounced them dead at 3:45. So their time of death is somewhere between 3:30 and 3:45. So we've identified the pronouncement time for the individual. We've determined that they're no longer alive. Now we need to make sure that we have the correct person. And there are a number of ways to do that, the most common of which is just visual. If the visual does not happen because either there's no one there who knows the decedent, or if the body has begun to break down and it's not possible for a visual to take place, we will move on to scientific identification. We'll take a look at images that were taken before and after death, and we'll compare the two. Or we may do fingerprints that the law enforcement has taken before the person died, and that could be for criminal reasons, it can be for immigration reasons, but we'll use those fingerprints and we'll compare them to fingerprints that were taken after the person has died. We may take a look at dental x-rays and compare the two. Or last resort, we'll take DNA from a loved one, a living person, a relative, and compare that to the DNA of the dead person. And the reason why we do that as a last resort is there's only one entity that has a very short turnaround time for DNA, and that's the military. The military hopes that they can have their identification of a soldier or military personnel done within a very short period of time, and they will try and do that within 3 days. For the rest of the world, it can take upwards of 6 months to a year to get DNA results turned around, because the DNA lab is not only working on the comparison for the decedent, but they're also working on cases in the criminal courts. So they're talking about identifying a perpetrator in a crime, or doing a sexual assault kit comparison. Now, unfortunately, although visual tends to be the most common, it can also be the least reliable. And so when you're doing identifications, you want to make sure that you're talking to a relative, someone who knows this person and has known them for a long period of time, or you're talking to a neighbor who's been around this person day to day for a long period of time, or you're talking to a coworker. One of the issues that we have is that there's sometimes when people make mistakes and they try and use identification cards, or they take a look at photographs. This is a case out of Arizona where these two individuals were in a car accident. One survived and one died. And it wasn't until a long period after the death, with one person who was in a coma, that the medical examiner sought dental comparison for the deceased person and realized that EMS and other personnel had actually switched identifications for these two individuals. Another case is these are 2 of 4 individuals who were in a motor vehicle accident. They thought that one of them was in the hospital. The family buried the other one. And it wasn't until the one who was in the hospital was going through physical therapy and other methods to get healthy that they kept calling her the wrong name. And she kept saying, no, that's not my name. My name is. And at that point, the family, who had initially thought that it would be too traumatic to try and do an identification on scene, the medical examiner actually worked with them, and they were able to identify that, again, the identifications were switched. So now that we've identified the remains, we're going to move on to the performance of an autopsy. Let's try that again. I think we jumped one. We jumped a couple. Okay, so we're going to move on to the performance of an autopsy. And we're going to start with our external examination. The external examination is going to be documenting the demographics, the identifying features. We're going to look for medical intervention. We're going to look for natural disease. We're going to look for trauma. You never want to mistake medical intervention for trauma, because that can turn out badly in the court of law. In the examination of the body, if it is a criminal case, we will also take evidence, and we will also do imaging. Documentation comes in multiple different forms. It is in written form, in artistic form, and also in photographic form. We will look at whether the individual is male or female, old or young. We'll take a look at whether or not they're thin or whether they're obese. We'll take a look at skin color. We want to be able to document the color of the eyes, whether or not they have tattoos, whether or not the nose is appropriately shaped, the condition of the teeth, the color and the length of the hair. We'll take a look at tattoos and scars, and some scars and tattoos will mean more than others. In the tattoo that is in the very center, this identifies someone as a diabetic. In the upper right, it identifies someone with asthma who may need an inhaler. There is a scar overlying a pacemaker in the center of the image. At the bottom of the image, there are multiple scars that are associated with what is loosely referred to as hesitation marks, and they can be indicators of self-harm. And in the lower right, these are tattoos that were used to cover track marks or scars that are associated with intravenous drug use. We'll look for evidence of natural disease. There is an image on the upper left of an individual who has tar staining or tobacco staining. That person may have a barrel chest. And in those cases, we'll look for lungs that are associated with COPD or chronic obstructive pulmonary disease, typically seen in smokers. In the image on the lower left, we can see someone who has yellowing of the eyes or icterus. The skin is also yellow, associated with jaundice, and that can be associated with changes to the liver. Here we can see 3 images of the liver. To the left of the image is a healthy liver. To the center of the image is a fatty liver, and that fatty liver can be associated with alcoholism. It can also be associated with obesity. And in the image on the right, that is a picture of cirrhosis, and that is the last stage of damage to the liver. And at that point, that's when the liver does not function the way that it should, and it results in the backup of the substances that the liver should be clearing out of your body, resulting in that yellow hue to the body. On the right side of the slide, we can see a central midline scar, usually associated with some kind of heart surgery. And we can see changes to the lower extremities, to the shins. This is stasis dermatitis. This is where the fluid in the body is not circulating the way that it should, resulting in fluid seeping into the tissues of the lower extremities and causing damage to the lower extremities. And in those cases, we'll expect to see some kind of damage to the heart, either heart disease or an enlarged heart. And then, as I mentioned, there is medical intervention. You can see a yellow piece of material in the center of the slide, and that is attached to a needle, and that is a device that's used to allow release of air in cases where there's damage to the lung. It can also release fluid and blood in some cases. Now, when that is removed from the body, all I will see is a puncture mark. And that puncture mark could be a stab wound from something like an ice pick, or again, it could be this decompression thoracotomy. So again, I want to be aware of what has been done to the patient as they're dying, so that I will rule that out as causes of trauma. And then finally, I'm looking for trauma. I'm looking for bruising. I'm looking for tears or lacerations. I'm looking for raccoon eyes. And when I see raccoon eyes, I think about damage to the head in some place that is away from the eyes. So yes, you can punch someone in the eyes and you can get a bruise to the eye itself. But if you damage or you bruise the scalp is so vascular that it can cause blood to seep down under the skin and settle around the eye, causing this raccoon eye. You can have bleeding or hemorrhage. Bleeding from the ear is very significant, and it makes us think of basilar or base of the skull fractures. And if you take a look at the X-ray image, you can see that there's a very thin line that is extending across the base of the skull, and that's that fracture that goes along with the bleeding from the ear. Again, very thin line going across the base of the skull. We can see sharp force injuries. This is an incision or a cut, or we may see just superficial damage to the skin or an abrasion or scrape. Then we'll move on to the internal examination. And when we do our internal examination, the body is washed. And so if there's any evidence that's on the body, we want to make sure that we're taking it before this washing process is taking place. When we do our internal examination, we'll also be taking samples to take a look at under the microscope. We'll be taking samples to run for toxicology, looking for both illicit drugs and medications. We'll take a look at the brain. The brain is a very complex structure, and sometimes it is necessary for us to have the brain looked at by a specialist. And when we do that, that is neuropathology. We may also look at evidence of infection, and we may look at the electrolytes, and we'll do that by looking at the fluid in the eyes. Now, when we look at television shows, when they do their internal examination, they're always dressed in their street clothes. They're not wearing masks, and everything seems to be okay. When I get into the autopsy suite, I'm typically covered. I've got on some type of outer protection. I have on an apron. I have something to cover my head, and I have a mask on. Now, this is a very good representation of what we typically look like, but what he's missing is a face shield. And the reason why he's not wearing his face shield is that the body is probably still sealed or closed. Now, this is examples of an internal examination. And so we have the intestines, we have the lungs. This is a lung that has a very large tumor to it. The lungs on the lower right side of the image are lungs that are from a smoker. So you can see that the very dark material, that's tar that's actually settled into the lung tissue. Moving up from that, this is a liver with fatty change to it. So we can see that there's that yellow change to the liver. And then there are coronary arteries, so vessels that feed the heart. In the top right image, you can see that that vessel is almost completely blocked. And as a result of that, there is changes to the heart muscle. In this particular case, this individual had a heart attack previously, and that heart attack weakened the muscle, and that muscle finally gave way and tore. So there is that tear in the heart as a result of a heart attack. Now, when we are taking a look at our cases, we may take a very short period of time to do our external examination. We may take about an hour to do x-rays or imaging. And when we do imaging, we're looking for fractures to bone, but we're also looking for evidence of violence. So we're looking for retained projectiles. We're looking for the tips of knives that sometimes get embedded into bones and break. We can do our internal examination, looking at all of those organs within about 35 minutes. If it is a very complex case, it may take longer. To get those samples back to look under the microscope, it can take anywhere from weeks to months. Toxicology, looking for drugs and medications, that can again take weeks to months. The neuropathologist needs to examine the brain in its form as it comes out of the skull. But we want to make sure that when we are cutting into the brain, that it is firm. Normal, natural, as it comes out of the head, brain tissue tends to be very soft. It's like flan. Or rice pudding. So when you cut into it, it tends to fall apart and it sags, whereas we wanted a consistency more of Jell-O. Now, I'm sure that you've heard this before, but pathologists love their food comparisons. So there's a food comparison for you. So when you cut into Jell-O, it may wiggle a little, but it's going to stay in place. And that's the texture that we want when we're looking at the brain tissue. So again, it takes us a little while to get to that particular texture. And then we need to make slides to look at under the microscope. And then we need to get a report that's written by the neuropathologist. So that can take it about 3 to 4 months. The microbiology, which is the looking for the infection, that can be about 1 to 3 weeks. Looking at the fluid in the eyes and the electrolytes in the body can take a couple of days. And if unfortunately we've gotten to the stage of decomposition where we're seeing only bony structures, then we may have to send that to another institution for evaluation, and that can take up to 6 months. Now, all of this, remember that some cases will have all of these different components. Some cases will only have a few of them, but all of these things are necessary for us to determine the cause and manner of death. Now let's take a look at some common misconceptions. So drowning, everybody talks about the fluid in the lungs. You got to look for fluid in the lungs. Well, I can tell you that of the 4 images that are here, only one of them is the result of a drowning. Image A is as a result of heart failure. As the heart fails, fluid starts to back up into the lung tissue and it can produce a foam cone. Image B is a case of seizure disorder, and that seizure disorder again produced fluid within the lungs and caused that to be present within the nostrils. Image C is as a result of a drug overdose. And in the medical examiner field, this tends to be the type of case where we will typically see fluid in the lungs or a foam cone. And image D is actually the only case in this particular group that resulted from drowning. Let's talk about fires. People think that they can burn a body and it's very simple. Everything's a-okay, you know, the body disintegrates and they've hidden their crime. Well, that's not actually true. When a body burns, the bony structures tend to stay in place. And typically a fire is extinguished before the body actually is completely burnt. We can tell whether or not an individual was alive at the time of the fire, and typically we'll do that at the time of autopsy by looking within the airway. And we're looking for soot in the airway, that black particulate matter that comes from the fire. And when we see soot in the airway, it's indicating that somebody is actually breathing. They're inhaling that dark particulate matter and it's settling in the airway. However, there are cases where the only thing that we will see is charring to the body. Now, what I can tell you is that of all of these cases that I've shown you on this particular slide, 2 of them are not as the result of a fire death, but actually they are gunshot wound deaths where the perpetrator tried to hide the crime by burning the body. Now, when we're looking at fire deaths, one of the things that we will look for is carbon monoxide, and that's the same chemical that your smoke detector is going to pick up. Carbon monoxide binds to your red blood cells, and they actually prevent oxygen from binding to those cells. They're kind of selfish. They kind of hang on to those cells. And as they build up within your blood, they tend to give you different symptoms. So you may start off with a headache, and then you progress to dizziness. There may be some vomiting. By the time you hit that 50% mark, you're in very dire straits, and you are at that point fainting, going into a coma. And we can actually test the blood at the time of the autopsy to determine what your carbon monoxide level is within your blood. When we're looking at thermal cases, we want to look at the circumstances of death, but most importantly, we want to rule out trauma to the body. We want to make sure that we are seeing whether or not there are broken bones, or there are gunshot wounds, or there are sharp force injuries, and that those things are not hidden by the thermal injuries. Seizures. In a case of seizure disorder, typically the brain looks very normal. It looks like an individual that doesn't have seizure disorder. There are some times when we may look at cases and we may see trauma. And one of the things that we want to make sure is that we are trying to figure out whether or not that trauma is what's resulting in the seizure, or whether or not the person had a seizure that then caused them to suffer some kind of trauma. The other thing that we will look at is a structure called the hippocampus that sits on the bottom of the brain. And the hippocampus has this seahorse shape. And when someone suffers a seizure disorder for an extended period of time, they may have damage or firmness to their hippocampus. The problem is that you can have situations that can cause firmness to the hippocampus that then results in the person having seizures. So we kind of have a chicken and egg scenario where we're not sure whether or not the seizures are causing the damage to the hippocampus, or whether the damage to the hippocampus is causing the seizures. Heart attacks. So heart attacks are caused by blockage of the vessels. Usually the vessels get smaller and smaller. The lumen gets smaller and smaller. And then finally a clot comes along and blocks the residual lumen that is present. And here we see another indicator, another image that shows the tightening of those vessels and the clot within that vessel structure. Now, when the vessel is completely blocked, the heart muscle starts to die. And there is a common misconception that medical examiners can always identify a heart attack. Now, I want you to take a look at this image. This shows a table of how long it takes for medical examiners, for pathologists to see changes within the heart muscle. And you can see in that second row that it takes survival of up to 4 hours before you can see something under the microscope. 4 hours to 12 hours after your heart attack, if you have survived your heart attack, that's when we can start seeing changes in the heart muscle with the naked eye. Now think about that. We are unable to put the entire heart in to slides to take a look at under the microscope. And so when we don't see anything with the naked eye, we're kind of feeling around in the dark. We're blindly trying to find that area that is damaged by the heart muscle. And sometimes we're lucky, but most of the time you can't select the exact section that shows you under the microscope that something's different. But if you can see something with your naked eye, then you can take a section of that and then you can take a look at it under the microscope and you can see all of the changes that are available. So when someone has a heart attack and dies immediately, it is not possible for us to be able to identify the heart attack. We can, however, document that there is significant heart disease, that there's significant blockage to a vessel. We may also be able to identify that the person has recently used drugs like cocaine or methamphetamine that will cause shrinkage of those vessels, and that shrinkage can result in damage to the heart muscle and result in a heart attack. So here are some of the images you've seen before. So again, some vessels that are very significantly stenosed or blocked with very little left for the lumen for blood to pass through. The damage you can see with the naked eye to the heart in the image on the left top. And if you look at the image on the bottom, you can see that there's a little area of red-yellow change. That's one of the earliest signs of damage to the heart muscle. So that's what we're looking at the 4 to 12 hour mark. And that's what we're hoping to see, to be able to take sections of that to look at under the microscope to confirm that this is the reason why that individual is no longer with us. Okay, the weirdest thing I've ever seen. I was standing next to a body. It was unfortunately skeletonized, and the autopsy tech who was working with me said, "Do you know that maggots jump?" I was taken aback and I said, "No, they don't." And he says, "Yes, they do." And at that point, I looked down at the body at a maggot and I saw it roll itself up into a ball, as we can see with these images here. And then it took off into the air and landed on another spot. Now, I can tell you that I don't like maggots. It's one of the worst parts of my job. And so when you tell me that the maggots no longer stay in the place where I see them and they can jump from one place to another, that becomes a problem for me. So I'm usually very conscious when I'm looking at bodies and I'm looking to see whether or not they're folding up in a ball. If they're folding up in a ball, I'm moving away. So this is the weirdest thing that I've ever seen. Okay, I think that's it. Any questions?
Thank you so much for that amazing talk. And yes, I open the floor for anyone that has any questions.
I have a question.
Oh, go ahead, Jim.
John, you can go ahead.
First of all, fascinating. Thank you very much. What prompted you to go into this field?
There's a sign on my door that says, "You don't need to be weird to work here. We'll teach you." When I was growing up, I actually wanted to be a veterinarian. I wanted to work with marine animals. There's a very big problem with that, though. I don't swim very well. And unfortunately, marine animals are not going to come on land just so that I could, work with them. So I went and I talked with my pre-med advisor, and she said to me, I know that you love criminalistics, and I know that you love medicine. Maybe forensics is something that you can take a look at. I ended up losing an aunt right around that time, and because of cultural decisions, kids are not really told about death and the reason why an individual has died. So those things kind of culminated with me taking a look at the California Coroner's website. And at that point, I spent about an hour on the website, and I was completely convinced that this was the world for me. And here I am.
Thank you.
You're welcome.
Hi, Dr. Granger. My name is Jim Reynolds, and thank you again. I agree with John. It was a fascinating talk.
Thank you.
My question, it's a little bit public and maybe a little too contemporary, but I'm thinking about Bob Saget and the manner in which he died, and the information that had become public, which is that he suffered a head trauma and then went to bed and fell asleep perfectly calmly, and because of a subdural hematoma, or passed away. And then it came out subsequently that there were substantial fractures to his head. And I'm not going to ask you to speculate about anything that's not public knowledge, but I'd like to get your comment on what you've heard that's been publicly available.
Sure. So this is unfortunately something that we see relatively often. I think part of the issue is that there is this perception in the world that you can't suffer significant damage without falling from a significant height. And that's not true. A lot of the falls that we see are from standing height. Someone trips over an animal, they trip over a walker, they lose consciousness, they get hypotensive, so their blood pressure drops and they pass out. And the weight of the body generates enough momentum for you to go down. And depending on what you hit on your way down, that can cause significant injuries. Now, in a lot of cases, that person may go, ow, my head hurts. But again, they don't think that they're significantly injured. And the easiest thing is, I'm getting a little bit of a headache. I'm just going to go lie down. I can take some Advil or, some Tylenol, and I'll be fine in the morning. And what they don't realize is that the damage is significant. There are fractures, there is a bleed starting, and that bleed can be gradual enough that that's the last thing that they're aware of, because as they're sleeping, that blood is building up around the brain, and the brain's very, very, very temperamental. So it doesn't like anything on its surface other than cerebrospinal fluid, so that clear fluid kind of washing over like a waterfall, gentle waterfall. So if there's any kind of blood very close to the surface, it tends to react very negatively. The other thing is the brain is in a fixed structure. The skull doesn't necessarily move. And so the brain, as it starts to react, starts to swell. And when you have blood that's pushing down on it and it's trying to get bigger in that tight skull, there's not a lot of places for it to go. And it starts to go places where it's not supposed to be, which causes even more damage. So again, we tend to see a lot of falls from just regular standing height. Some people fall out of chairs and they cause significant damage. So this is not unheard of. This is relatively common. And the takeaway is, if you fall and you hit your head, it's better that you go to an emergency room or go to an urgent care center, get yourself checked out, make sure that everything is okay, then you can go home and sleep. Don't sleep first and then think that you're going to be able to go to the doctor the next morning.
Thank you.
You're welcome.
And we got another question in the chat from Lauren. She says, I've been keeping up to date with the county website. Are there any internships in the medical examiner office being offered this summer 2022?
Okay, so unfortunately, COVID-19 has put a significant damper on our activities. And the website has actually indicated that internships are not available this spring, this summer, or this fall. What I would recommend, as things are starting to open up again, fill out that that application form that is on the website, because there are a number of different sets of paperwork and agreements that need to be in place for you to spend some time at the medical examiner's office as an intern. So it is a good idea to kind of get those agreements in place sooner rather than later. And you may not be able to do it in 2022, but hopefully we'll be back open in 2023 and you guys can come and spend some time with us.
Yes, John?
Another quick question. In all this time, I mean, you've had great experience. Is there one case that sticks in your mind that to you was fascinating?
There've been a number of fascinating cases. There are cases that tend to defy the medical literature. There are scenarios that people create for themselves that may seem impossible in the world, but we've seen evidence of it. There are cases around the country where people have managed to shoot themselves in the back of the head and make it seem as though it's a homicide when it's actually a suicide. We've had cases where people have attempted to poison others and have attempted to hide their crimes only to have them come to light for silly reasons. They forget something on a table. But the one thing that I've learned in the time that I've been doing this is that the cases that stick with you are not always the cases that you think will. I've seen horrific child trauma and horrific neglect, but the case that affected me the most was the case of a 5-year-old who appeared quite normal the night before she died. And I did the autopsy and I did everything that I could possibly do as a medical examiner to try and determine the cause of death for those parents. And I could not find one. There's a misconception out there that medical examiners always have the answers, that an autopsy will always show you the cause of death. And when I was going through my training, that's one of the things that I believed. And after that case, I found myself distraught. I was hysterical with the family on the phone. And that family ended up supporting me and consoling me because they understood that there are limits to science. And as I mentioned before, when I was talking about heart attacks, there's no way for us to put every organ through sections to take a look at under the microscope. And so there's always a possibility that what we're looking for is in the next section that we didn't take. There's always the possibility that the change that we were looking for is in the next sample, but not in what we have within our grasp. Or that simply the technology hasn't caught up with everything that we need to know about the human body. And we have to go into our cases knowing that there is not always an answer, but we do everything in our possibility to attempt to find that. And that's what stuck with me through all of my experience.
Thank you.
You're welcome.
Wonderful talk.
Thank you so much.
Oh, sorry, we have one last question from the chat, which is, what are some steps I can take to prepare myself for a career in pathology?
So one of the things that I did was I went to contacted my local medical examiner's office and expressed an interest directly to them. I did a lot of my early training in Brooklyn, New York, so downstate. And I simply called up the medical examiner's office and said, hey, I'm a college student and I'd really like to come talk to the forensic pathologist. We love to teach. We love to have interactions with students. Forensic pathology is a field that is in desperate need of new faces. We are probably about 50% of what we need in the world to be able to adequately cover all of the offices that are in not only in the US, but worldwide. And so the more people who get involved, the better it is for us. So we always like to make ourselves available. Call our office, send an email to medicalexaminer@monroecounty.gov and express your interest and sign up for those internships. The other thing that you can do is reach out to the University of Rochester. The University of Rochester has a program that allows students, including medical students, to be a part of their office, their pathology department, and also to allow rotations through the medical examiner's office. So that's another good contact point for someone who's interested in pathology.
Excellent. Thank you so much again.
I actually have
You
a
are
question
welcome.
for you. I'm Jenna. I'm a undergraduate student at Nazareth College, and I'm actually the vice president of our pre-health club. And we have quite a few students this year, and actually been increasing in the past few years, interested in that they actually want to be you. And so we wanted to know if you ever spoke to other colleges, or if you'd be willing to come speak to colleges. It could be virtual, in person, whatever's up to you. But so many students are interested in what you do. And because of COVID, it's really difficult for internships and things. We were wondering if maybe even just you coming to talk would be enough to spark interest and kind of more education around what you do and how to get more involved.
So as you know, we are really busy, but as I mentioned, we are always trying to get the word out there. And so I would be happy to.
That's great, thank you. So how do we go about kind of starting that connection process to kind of get that ball rolling?
So if you send an email to medical examiner, no spaces, at monroecounty.gov, you will make contact with my chief investigator, and he will pass those requests on to the medical examiners.
Thank you so much. I really appreciate it.
You're welcome.
All right, awesome. Thank you so much, Gina. That was a really nice interaction. I hope everything goes well with that connection. Only good things for sure. All right, so now our closing remarks. James is gonna let us know what's happening with the local section events.
Yes, so we have so if you would like to get more involved with the American Chemical Society's local section in Rochester to put on more amazing events like this, or just to help out and network and get more involved. We have various open positions and lots of events coming up. We have a mixer for the Younger Chemists Committee next week. We also have the annual meeting for the local section as well, where we give lots of information of all the events that we had in the past year and coming events. We also have the Collegiate Research Symposium on March 9th and the Northeast Regional Meeting in October. And you can also join our social media accounts as well. All right, next slide. So thank you everyone for attending. Thank you again, Dr. Granger, for coming and giving this presentation to us. We also have a survey for attendees to give any feedback so that we can improve future events. And let's give another round of applause for Dr. Granger. All right.
Right. Thank you, everyone. Have a good night. Thank you, Dr. Granger. We'll keep in touch. We'll keep in touch. Thanks.